So today we would have a small session on anti-leprotic drugs. Even after so many years, almost in 55, National Leprosy Control Program was launched. And even today we don't have many anti-leprotic drugs, number one. Number two, it is experienced that they are not even needed because the drugs which are available, they are still effective. So leprosy, again, we also call it Hansen's disease. It is again a chronic granulomatous disease like tuberculosis, but tuberculosis mainly infects lungs. Leprosy infects skin, mucous membrane, and nerves mainly. The main problem is nerves. The drugs which are available are, as I told you, very few of them. Main drug, the 2-3 of them, one is dapsone. They are sulfones, basically we call them, but that is only one drug, that is dapsone. Another is clofazimine, and third is anti-tubercular drug, that is rifampicin. Ethionamide also is effective, but because of toxicity rarely used. Actually we don't use it because now we have other drugs which are effective, like fluoroquinolones, ofloxacin, moxifloxacin and sparfloxacin. 3 of them are used. We have minocycline, that is very effective. So clarithromycin, amongst macrolides only clarithromycin is found to be of utility. So because of these drugs, ethionamide is no more used. This is dapsone, that is also known as SDA. SDA means 4,4-sulfonyl dianiline, or DDS. In the older books you will find very commonly written DDS, that is diamino diphenyl sulfone. This is the structure, diamino diphenyl sulfone, chiral. If you see, if I put S here, O above and below, so this becomes a symmetric structure. So this is diamino diphenyl sulfone, DDS. We will only talk about 2 drugs. One is dapsone, another we would talk about minocycline, because clofazimine is already covered under anti-tubercular drugs, second line anti-tubercular drugs. We talked about clofazimine. Rifampicin also is covered in first line anti-tubercular drugs. Fluoroquinolones, as we said, we will have a separate lecture on fluoroquinolones. But minocycline, because it has some other characteristics, so we will talk about minocycline, and then we'll talk about the regimens which are used for leprosy. So dapsone operates through a dual mechanism. One is anti-infective and another anti-inflammatory. Anti-infective is same like sulfonamides. This also inhibits synthesis of folic acid. It competitively binds to the enzyme dihydropteroate synthase, preventing the bacteria from utilizing PABA. So this is the same mechanism that we have for sulfonamides. Because folic acid is essential for bacterial DNA and RNA synthesis, this mechanism makes it highly effective against pathogens like Mycobacterium leprae, Toxoplasma gondii also, and Pneumocystis jirovecii. Anti-inflammatory mechanism is for chronic inflammatory skin conditions such as dermatitis herpetiformis, Dapsone limits immune system driven tissue damage. So it's basically an immunosuppressant. It suppresses the activity and migration of neutrophils to the site of skin lesion. It prevents neutrophils from releasing cytotoxic chemicals such as myeloperoxidase and reactive oxygen species, respiratory burst that happens. It interferes with inflammatory mediators like leukotrienes, particularly leukotriene B4. Actually, many cytokines are inhibited. TNF alpha also is inhibited, which normally attract immune cells to inflamed tissues. So this is the standard anti-inflammatory mechanism. One is chemotactic, anti-chemotactic activity is there. Cytotoxic chemicals like myeloperoxidase and reactive oxygen species are prevented, they are not released, and migration, as I said. So this is also an anti-inflammatory. Common side effects, these are common: GIT, nausea, vomiting, loss of appetite, pain in abdomen or backache, and these are neurological: headache, dizziness, nervousness, insomnia. Photosensitivity is important, actually both this and minocycline also. Hematological effects, remember when we talk of adverse effects of dapsone, then 3-4 of them become very important. One is hematologic effects. In hematologic effects, almost always mild degree of hemolysis and methemoglobinemia is observed, and because of that lips or fingertips appear slightly blue in color. This is a normal side effect. Depending on different types of G6PD, there may be different amount of methemoglobinemia or hemolysis, but it is always there. G6PD deficiency people are at a higher risk of developing hemolytic anemia. Actually, some people, they recommend that we should go for G6PD status before giving dapsone. It is such a common problem, and rarely aplastic anemia. That will manifest as fever, sore throat, easy bruising or prolonged bleeding. So another. And then hepatotoxicity, jaundice is very common, and peripheral neuropathy. Peripheral neuropathy will express as muscle weakness or burning, numbness in this thing. But what is more important are this dapsone hypersensitivity syndrome. Dapsone hypersensitivity syndrome and Lepra reaction. Dapsone hypersensitivity syndrome is a delayed hypersensitivity reaction. So 4 to 6 weeks after starting treatment, or even after completion of treatment, you can see it, means it can be very much delayed. The classic triad of this syndrome is characterized by a triad of fever, skin rash, and internal organ involvement, particularly lungs and liver. They are involved. There is a genetic risk strongly linked to a genetic marker known as the HLA-B1301 gene, more prevalent in Asian populations. Management: immediately stop dapsone, and actually permanently. Don't use it again. And remember, in case of clofazimine also we talked about that when we give it, the amount of steroids can be decreased. Here also we need to give steroids if it is very severe. Otherwise clofazimine is already being administered. It's a combination therapy. If required, we have to go for prednisolone, 40 to 60 milligram every day. So corticosteroids are required. And Lepra reaction, type 1 and type 2. This is immediate type, Arthus type of reaction, like what we see in syphilis also. Here also this is an Arthus reaction. Acute immune system responses to the Mycobacterium leprae bacteria themselves, which happen naturally as multi-drug therapy begins to kill the bacteria. They are not allergies to dapsone. So always remember, they are not allergy. So delayed hypersensitivity type of reaction is different, and lepra reaction is because of, as I told you, it's an Arthur's type of reaction. Type 1 reversal reaction results in sudden inflammation of existing skin lesions, redness and severe nerve pain, which can lead to permanent nerve damage. This is type 1. And type 2 is known as erythema nodosum leprosum, ENL. It causes painful tender red nodules under the skin, often accompanied by fever, joint pain and nerve inflammation. So this is more diffuse and more serious reaction, erythema nodosum leprosum. It can be very serious at times. So we have to remember, when we are talking of dapsone, adverse effects also, hematological adverse effects, hypersensitivity delayed, that is dapsone hypersensitivity syndrome and lepra reaction. These three are very important, and two more I told you. One is hepatotoxicity, another is peripheral neuropathy. So these are the adverse effects of dapsone. And what are the uses of dapsone? Just like we said, it's an anti-inflammatory also. So leprosy is, yes, in combination therapy. Dermatitis herpetiformis controls the intense itching, bumps and blisters caused by gluten sensitivity. So that is one of the indications. Acne vulgaris, both because of antibacterial and because of anti-inflammatory. So acne vulgaris is indication. Off-label uses, pneumocystis jirovecii pneumonia, for prophylaxis and treatment in immunocompromised patients like HIV. Autoimmune blistering disease like pemphigus vulgaris, bullous pemphigoid and linear IgA disease, that is used by dermatologists and specialists. And severe inflammatory skin conditions, neutrophilic dermatosis like pyoderma gangrenosum and sweet syndrome. Sweet syndrome, again autoimmune disease that you can read. It's a full-fledged syndrome. So these are the dermatological indications where off-label it is being used. Then another drug, as we said, it's minocycline. Minocycline is, we know it's a tetracycline group of drug, but we will talk about them. Broad spectrum tetracycline antibiotic. So see, the structure is different. It's multicyclic structure. This is a structure like tetracyclines. Antibacterial mechanism. It also has some anti-inflammatory property. That is why we are talking about minocycline. So antibacterial, we know tetracyclines, they are protein synthesis inhibitor. So what happens, there is binding, minocycline penetrates the bacterial cell wall, they are highly lipophilic. So they cross easily, binds to the 30S ribosomal subunit. This binding physically blocks amino acyl tRNA from attaching to the mRNA ribosome complex. Remember, initiation complex is formed initially with the help of mRNA, binds to ribosomes. So after that, the amino acyl tRNA comes and binds to this initiation complex that we call it, and this is how the prolongation takes place. So what happens, by preventing the addition of amino acid, the bacteria cannot synthesize the protein. So basically, just remember, you have to read how the protein is synthesized. Amino acyl tRNA transfers basically amino acid in sequence. So that is prevented. So very simple, straightforward mechanism of minocycline as antibacterial. Anti-inflammatory and neuroprotective properties. Minocycline is highly lipophilic, easily cross blood-brain barrier, and so actively modulates immune and central nervous systems. Microglial inhibition prevents the activation of microglia. Microglia are basically immune cells. reducing inflammation in conditions like stroke or multiple sclerosis. Enzyme suppression directly inhibits pro-inflammatory enzymes such as inducible nitric oxide synthase, COX-2 and matrix metalloproteinases. So all these enzymes are inhibited. Anti-apoptosis property is also there. It blocks the activation of caspase 1 and caspase 3, which prevents cell death and preserves tissue in neurodegenerative disorders. So these are other characteristics of minocycline. Dermatological action. Minocycline also has dermatological action. Actually, I remember when I was an undergraduate. So amongst undergraduates, acne is the biggest problem. They just keep searching for drugs for acne. And I remember this was the time when minocycline, and as usual in minocycline, we try everything, but nothing works. So throughout MBBS, I was trying to find out some effective drug, and I remember when I was in final year or I was an intern, then our dermatology department started prescribing minocycline for acne. So this also was tried by everybody, minocycline, and this became like very effective drug for acne, but it was as effective as other drugs. But acne, because it has multiple activities, it has antibacterial, it has anti-inflammatory also. So because of its higher lipid solubility, minocycline easily dissolves into the lipids of the skin sebaceous glands. This allows it to reach highly targeted concentrations deep within hair follicles, where it directly attacks the bacteria responsible for acne. Cutibacterium acnes, while its anti-inflammatory properties reduce redness and swelling. So both the effects are seen at the same time. That is why this became very popular as an anti-acne drug. Common side effects. Within the first few days of starting the medication, we get neurological, GIT and skin. Neurological, like dizziness and lightheadedness, is very common. Vertigo or mild headaches, vertigo on prolonged use. GIT, nausea, vomiting, diarrhea, indigestion and dry mouth, they are seen. Skin, increased sensitivity to sunlight. As I said with Dapsone also, this was a big problem here also, making severe sunburns more likely. Itching and changes in the color of the skin, nails or gums. So these are common and these are serious. One is intracranial pressure, severe headaches, blurred vision or vision changes. This is known as pseudotumor cerebri. So we have to remember with minocycline. Autoimmune symptoms of drug-induced lupus such as joint pain, stiffness, fever and extreme fatigue. Liver or kidney damage, jaundice, severe upper abdominal pain, dark urine or pale stools. Severe intestinal issues like persistent, severe or bloody diarrhea, which may indicate Clostridium difficile infection. So that there is a possibility of this superinfection. Allergic reactions, severe skin rashes, blistering or swelling of the face, lips or tongue. This is also very common actually with most of the antimycobacterial drugs. These are the precautions that we have with all tetracyclines. Tooth and bone development generally not recommended for children under 8 years of age. It can cause permanent discoloration of teeth. Pregnancy and breastfeeding, it can affect the bone growth and teeth of developing fetus or infant. Birth control, oral contraceptive ineffectiveness. Sun safety, limit prolonged sun exposure, always use a broad spectrum sunscreen, SPF 30 or higher, and wear protective clothing when outdoors. So these are the precautions with minocycline. What are the uses? One is bacterial infections, pneumonia, skin infections, and certain infections spread by ticks, lice, and mites. It's a tetracycline. So broad spectrum, tetracycline are broad spectrum. Acne and rosacea effectively reduces pimples, red bumps, and inflammation by targeting pore infecting bacteria and decreasing skin oils, sebaceous glands. Alternative treatments, often used as an alternative for penicillin allergic patients to treat conditions like anthrax or certain types of food poisonings. Leprosy in the books you will not find as one of the indications. I have written it because we are talking of anti-leprotic drug. There it is used as a replacement. So in the chapters of broad spectrum antibiotics, we will not find this indication, but we should include it. So now we come to how to treat leprosy. As I told you, leprosy, National Leprosy Eradication Program, Leprosy Control Program was launched in 1955. But then in 1981, WHO Action Plan was launched. And in India in 1982, National Tuberculosis Eradication Program was launched. So it was till then it was control program, then it became eradication program. Eradication means one case per less than one case per 10,000 population. So in India, most of the states are, we can say, have eradicated when it comes to this definition. Some of them they are not. And actually India is a country that is unique in harboring the maximum population of leprosy patients. Even till 10 years back, when this was found out, there were almost more than 1 lakh new patients every year. So even now this is a big problem. So how to treat it? I won't go in details of more of the demography because we are talking about pharmacology. So for that we have to remember how do we classify leprosy. We still use this Ridley and Joplin classification that was given in 1966. He divided leprosy in 5 classes. One was lepromatous leprosy, LL, borderline lepromatous, BL, borderline BB, borderline tuberculoid, and tuberculoid, that is TT. So these 5 classes were. So what is the basic difference between lepromatous and tuberculoid? We use other terms which are used by WHO. WHO has given other terms like paucibacillary and multibacillary. So they are also based on this classification by Ridley and Joplin. So the features of tuberculoid, there is one or more anesthetic patches. There is no diffuse disease. There are well defined anesthetic patches there. Cell mediated immunity is normal. Lepromin test is positive. No bacilli in biopsy. We take skin biopsy from the lesions. There is no bacilli. Prolonged remissions, and rarely there are exacerbation. That is the feature of tuberculoid. And lepromatous, it is diffuse skin and mucous membrane nodules, infiltration nodules. CMI is absent, so lepromin test will be negative. I have written positive. This will be negative. Skin mucous membrane regions full of bacilli. Progress to anesthesia of distal parts, and that leads to ulceration and atrophy of fingers, toes. That is characteristic of lepromatous. So these are the characteristics of tuberculoid and lepromatous. That is what Ridley and Joplin further classified it into. So when we have pure lepromatous, then we can call it lepromatous leprosy. When slightly lesser than that, then borderline lepromatous, then borderline tuberculoid, and tuberculoid. Actually, when we say multibacillary, That means we are talking about lepromatous. We are talking about lepromatous leprosy, lepromatous or lepromatous borderline. And when we are saying possibacillary, then we are talking about tuberculoid type of borderline or tuberculoid. Actually, WHO also gave one more class of leprosy, that was single lesion tuberculoid type, single lesion possibacillary, and another was multi lesion, when we have 2 to 5 patches of anesthesia patches. So when there is single patch, that is known as single lesion tuberculoid or single lesion possibacillary, SLPB. And when we have 2 to 5 patches, then we have multi lesion possibacillary, and 6 and above, that becomes multibacillary. So that is also followed. Which are the regimes which are used for treating this tuberculosis? Remember, unlike tuberculosis, where now we have very rigid laws also and regimes also, they are prescribed and you have to follow them. You cannot, because of the nuisance of tuberculosis. Since leprosy does not have that kind of nuisance, because remember, resistance is developed by Mycobacterium leprae also, but it is not a nuisance in the sense we again start the same treatment and it is effective. So even if the organism develops resistance, we do not need to change the regime, we just need to restart the regime. And that actually is a big problem in leprosy. Dormant organisms, the organisms may remain dormant for many years. So we feel that the person is treated, but again may come up after 5 years, after 10 years. Actually, the record says that it may reappear. We have to follow till 15 years. The person may come back after 15 years. So that is the big problem. Dormant organism is a big problem rather than resistance. That is why. So that is why I was talking about, like, these are the regimes when we say for masses we are giving them. But otherwise, if the physician is sufficiently experienced and the person can be followed, then there can be various regimes. There can be various regimes. But what we follow at large scale when we are giving to the masses, then what is this? For multibacillary, daily we give these 2 drugs. One is dapsone 100 mg and clofazimine 50 mg. In children, dapsone 2 mg per kg, clofazimine 50 mg, 1 mg per kg. This is given daily. And monthly, this is not only monthly, we have to write supervised also. Monthly supervised, rifampicin 600 mg per kg, 10 mg per kg, and clofazimine 300 mg, that is 6 mg per kg in children. So this is the regime for multibacillary. In possibacillary, we give only dapsone every day, and monthly we give only rifampicin. So 2 drug regime. Okay, so very simple. For possibacillary, it is 2 drug regime. For multibacillary, it is 3 drug regime. Rifampicin is given only monthly. So this is the regime for masses. But as I told you, if you have sufficient experience and the person is coming to you, you can follow up. Remember, as I told you, resistance is not a problem, but you have to follow the patient for at least 5 years. And actually that is one of the reasons. I have not written how long we have to give it. Remember, it was recommended for 24 months in multibacillary, and for possibacillary this was recommended for 12 months. The reason was the response is immediate, but you don't know what will happen to the patient, whether this will come back or not after completing the treatment. Now when it is observed that these patients can be traced, if the doctor is also confident, then this is reduced. Like possibacillary we are giving for 6 months and this is given for 12 months. So basically we call it MDT 12 or MDT 6. But as I told you, you have to decide how long you want to use them. You can, in multibacillary, even now you can go up to 24 months if you feel like, because the problem with monthly supervised is if one dose is missed, then it becomes a problem. So you can go up to 24 months. But otherwise, nowadays for multibacillary you go for 1 year, that is 12 months, and for possibacillary you go for 6 months. We have many other regimes. You may employ them for decreasing the duration, or you may use them if you have the fear of one drug is not being tolerated, like you have problem with dapsone, you have problem with rifampicin, you have problem with clofazimine, then you can go for those drugs. These are other regimes. One is intermittent ROM, rifampicin, ofloxacin, minocycline. Once a month in case of possibacillary, 3 to 6 months, in case of multibacillary, 12 to 24 months. But remember, once a month, there is nothing daily. So becomes very, as I told you, the regimes, fixed regimes are for masses. Here if you have affluent patients, you know they are very compliant, you know everything about the patients, then you can use all these regimes. So one is ROM regime, that is given once a month. Another is this longer regime. If you have suppose resistance to any of the drugs, say here there is no rifampicin here. So if you have resistance to rifampicin, the patient is not tolerating rifampicin, or patient is not tolerating dapsone, then we can go for such regimes. Here what we have, clofazimine is mandatory, 50 milligram plus any two of oflox, minocycline and clarithromycin. Clarithromycin when we give it 500 milligram. So one is clofazimine, that is mandatory 50 milligram, and any of these drugs. I have not written here how much because that is fixed. When you are giving ofloxacin, it means 400 milligram. When you are giving minocycline, means 100 milligram. Clarithromycin means 500 milligram. Sparfloxacin means 200 milligram. There is no differences in doses. So clofazimine 50 milligram plus any of these two. This is to be given daily for 6 months, followed by clofazimine 50 milligram and remove clarithromycin, any one of the oflox or minocycline, for next 18 months. So this is a 24-month regime. So naturally nobody is going to use it as a first regime. This is always for those cases who relapse. So you can go for this. And this is 4-drug regime: rifampicin, sparfloxacin, clarithromycin and minocycline daily for 12 weeks, only 3 months. So this is 4-drug regime daily for 3 months. This is also very effective. So here we have sparfloxacin 200 milligram. So these are the regimes which we have, but as I told you, if you have problem with dapsone, it is replaced with drugs like ofloxacin or minocycline. These are the drugs which can replace dapsone. So you have many of these regimes where you don't have dapsone. So if the problem is not tolerating dapsone, as I told you, hemolysis is a big problem. Lepra reactions. So if the person is having those kind of problems, then we have many of these alternative regimes. And as I told you, you can make your own regime also. This freedom is given in leprosy if you have experience with the drugs, but only these drugs which we have said, like in case of fluoroquinolones, as I said, only ofloxacin, moxifloxacin or sparfloxacin. These are the drugs which we use amongst tetracyclines only minocycline is used. So these are the anti-leprotic drugs, and that is how we use them. So very small topic.